Initiating explainer sequence. Welcome, candidates. I'm VASI, the Vascular Artificial Intelligent Agent created by Dr. Mohammed Almer El-Farak. I'm here to give you a high-yield synthesis of Rutherford's Chapter 20, specifically geared for your FRCS examination prep. Today, we're zeroing in strictly on the clinical evaluation of the venous and lymphatic systems. Think of this explainer as a way to literally download the most crucial concepts, pathways, and clinical decision trees right from the source text and into your active memory. Let's get started. Now, you might be wondering, what exactly are the FRCS examiners looking for? Well, they definitely aren't just looking for basic competence. They demand absolute mastery. As Rutherford specifically emphasizes, your ability to seamlessly blend deep anatomical knowledge with a highly pointed clinical history is the exact thing that separates a true specialist from a novice. It's not just about knowing the veins are there, right? It's about understanding how that specific anatomy drives a patient's unique presentation. To get there, you've got to build a mental roadmap, like this master algorithm from Chapter 20. You really shouldn't just be memorizing a random list of topics. You need to construct a diagnostic flowchart in your head. Everything is totally interconnected, from the foundational anatomy all the way to those complex evaluations of obstruction, insufficiency, and lymphatic disease. If you can visualize this syllabus map during your exam, you'll be able to instantly pull up the exact clinical pathways you need for literally any scenario they throw at you. To optimize your cognitive load today, we're going to process this explainer through 5 distinct modules: the diagnostic paradigm, modern practice guidelines, anatomy and evaluation matrix, pelvic and systemic disease, and finally, expanding lymphatic horizons. All right, let's jump straight into Module 1, the diagnostic paradigm. This is the fundamental clinical pipeline required for every single patient you see. This sequential flow is absolutely crucial. You literally can't skip steps here. A thorough, pointed history and physical exam directly dictate what diagnostic imaging you choose. You don't just blindly order an ultrasound, right? Your exam findings tell you exactly what imaging modality you need to confirm the disease process. And then, that confirmed imaging locks in your treatment algorithm. Believe me, examiners will penalize you heavily if you try to jump straight to treatment without building this rock-solid diagnostic foundation first. And within that paradigm, you've got to stratify your patient immediately. Is this an acute situation like a deep vein thrombosis that needs immediate intervention? Or are we talking about long-term management of a chronic issue like chronic venous insufficiency? That acute versus chronic binary is a huge pivot point in oral board scenarios, and it heavily dictates your very next move. Moving right along to Module 2, Modern Practice Guidelines. We need to talk about the non-clinical hurdles examiners expect you to navigate in the real world. You must be intimately familiar with the Appropriate Use Criteria, or AUC. These criteria were developed to standardize treatments like knowing exactly when to pull the trigger on compression therapy versus endovenous ablation, based entirely on rigorous research and expert consensus. If you're in an FRCS scenario and you justify your surgical plan by citing the AUC, you're proving that you're a safe, contemporary surgeon practicing evidence-based medicine, not just kind of flying by the seat of your pants. And look, this directly translates to the administrative side of things. Because venous interventions have gotten way less invasive and much more common, there's been a massive spike in procedures. Naturally, that brings intense scrutiny. You've got to be ready to navigate strict authorization requirements and complex rules from CMS and private insurers. It sounds like boring paperwork, I know, but a true specialist understands that these socioeconomic hurdles directly impact whether your patient actually gets the care they need. Okay, initializing Module 3, Anatomy and Evaluation Matrix. Let's break down the complex pathological groupings from Rutherford's text. Your foundational knowledge here has to be flawless. You need to rigidly classify both the superficial and deep venous systems. And here's a classic trap: do not just focus on the legs. The exam is going to test your entire anatomical map. You have to be able to trace the pathophysiology just as easily if the issue starts in the great saphenous vein of the leg or the basilic and cephalic veins up in the arm. Now, when evaluating the deep system, you absolutely must be able to contrast chronic thrombotic venous obstructions. A super high-yield area is comparing non-thrombotic iliac vein lesions, NIV, against post-thrombotic syndrome, or PTS. Remember, NIV is usually a mechanical compression thing, like May-Thurner syndrome. PTS, on the other hand, is driven by post-inflammatory scarring from a prior DVT. Your history taking has to stratify that etiology perfectly, because how you manage them interventionally is completely different. When it comes to superficial venous insufficiency, your differential diagnosis needs to be bulletproof. Yes, account for axial reflux as the main driver, but don't ignore the accessory and perforator veins. They are notorious culprits for recurrent ulcerations. Plus, you have to assess for complications like skin changes. If you do an incomplete evaluation of the superficial system, you're going to get incomplete treatment and recurrent disease. And for an examiner, that is a massive red flag. Module 4, Pelvic and Systemic Disease. Let's shift our focus to the central and specialized venous pathologies that love to show up in advanced board scenarios.
Evaluating pelvic venous disease is honestly like a complex puzzle of overlapping pathologies. You have to be on high alert for anatomical anomalies like left renal vein compression. We're talking the classic nutcracker syndrome here, while also checking for pelvic varicosities and congestion. These conditions are tricky. They require highly specialized imaging and a really nuanced grasp of pelvic hemodynamics.
And definitely don't sleep on those specialized systemic conditions. Venous thoracic outlet syndrome, popliteal vein entrapment, venous aneurysms. These are distinct mechanical or structural failures. They need totally different surgical or endovascular approaches compared to your standard reflux or thrombosis cases, which makes them prime targets for exam questions.
Finally, let's access Module 5, Expanding Lymphatic Horizons. We need to make sure you're fully prepared for the often overlooked lymphatic system. Failing to properly evaluate limb swelling is a classic FRC's pitfall. You have to be able to make a crystal clear diagnostic differentiation between lymphedema and lipedema. You've got to know those physical exam hallmarks cold. I'm talking about looking for Stemmer's sign in lymphedema versus spotting that characteristic fat distribution that specifically spares the feet in lipedema. If you confuse these two, your management strategy is going to be entirely wrong from day one. As we wrap up this explainer sequence, I want to leave you with a final thought straight from Rutherford's text. This field isn't static. Ongoing research is constantly revealing how disease presentation and outcomes differ based on sex, race, and socioeconomics. So, as you step into your role as a fully certified specialist, ask yourself, how is this evolving understanding and the reality of patient access to care going to rewrite the very algorithms we just memorized today? This is Vasai, signing off. Keep processing, keep synthesizing, and absolutely crush that FRCS examination.